Great. All right. Well, good morning, everyone. My name is Roshan John, and today I'm here to present about my internship experience this past summer. My topic is going to be on assessing telehealth modalities and their association with health disparities and health access. This will be in context of the data I got to work with from UNC Healthcare in collaboration with the Carolina Health Informatics Program here at UNC. Let me start with an overview. This internship experience offered me an inaugural opportunity to work in the context of health informatics research and get firsthand experience in examining telehealth usage patterns. For deliverables, I worked on an introductory literature review and data analysis of a telehealth dataset for a study paper. This was done in conjunction with Dr. Saif Khairat and PhD student Malvika Pillai as part of the manuscript writing process. The research paper was focused on comparing the usage of phone and video modes of telehealth during the months of March and April 2020 within the UNC urgent care system. It produces some insight into links between modality and differing health access or disparities. The internship for me spanned the months of May through July 2020. This experience was all remote, which presented a unique working experience to develop and sustain work cycles throughout the project. The internship was also a meaningful first exposure to working in health informatics for me and helped provide a learning experience about assessing health data to build on for future experiences in the field. In terms of my professional background and the goal of the internship, my background has been outside the healthcare industry largely, as Marielle mentioned, in the domain of IT, helping maintain the integrity of data within database systems, and being a consumer facing support technician. One of the main factors that drew me to health informatics is the interplay between people, information, and systems in a field increasingly relying on informatics initiatives to glean intelligence and inform future direction. As a result, the goal of this internship was to be an initial exposure to working with information and a dataset in a health informatics setting and to translate some of my past experience into experience relevant for the field. It would allow me to understand some of the needs, concerns, and priorities of working with healthcare data and what the impact of working in healthcare could have. Fundamentally, this internship experience is a foundational stepping stone to enter working in information management and data analysis domains within the field. About the where and who that allowed for this project opportunity. Well, the setting from which the dataset was sourced for this experience was the UNC Urgent Care 24/7 telehealth service. UNC Health partners with MD Live to deliver real-time physician appointments remotely across North Carolina and the country through either a telephone or a video visit. The visit data is warehoused at UNC Health and is the basis for the data analysis and inquiry done in this experience. The key collaborators on my internship experience were Dr. Saif Khairat, assistant professor at UNC Chapel Hill School of Nursing, and BMHI doctoral student Malavika Pillai here at CHIP. Key leaders who were attributed to this project were Barbara Edson and Robert Gianfrancaro from the Virtual Care Center at UNC Healthcare. Focusing on what was tasked for this project, I was involved in two main activities during the internship. The first was performing data cleaning and assisting in data analysis by running some statistical computations and generating information graphs from the data set for the months of March and April 2020, specifically from March 3rd through May 3rd of the year. The second key objective was to develop an introduction for the paper manuscript based on a literature review of existing telehealth initiatives comparing phone and video modalities. So why does this matter? Well, especially in this time of the COVID-19 pandemic, the value of telehealth has been made more evident and significant. There's a need to understand how telehealth initiatives are accessed by different demographics and what differing modes can mean for factors such as wait time or visit duration for the patient. Understanding these can help inform telehealth initiatives by understanding what patterns might exist, especially when it's based on data that comes from a service catering to a wide set of patients, in this case, predominantly across the state of North Carolina. So, what's the broader question this project sought to address? Well, it's assessing if phone or video telehealth modes are used more by certain types of patients, potentially along lines of existing health disparities in the setting of the COVID-19 pandemic. There was also interest in contrasting it with previous telehealth studies that have compared modality usage historically. This project focuses primarily on patients in North Carolina served by UNC Healthcare, but this kind of assessment is simultaneously being initiated in other US settings. One recent example is a study in rural Appalachia examining the implementation of telehealth in outpatient neurology during COVID-19 and how it relates to which patients chose phone or video modalities. This study indicated that patients that chose video visits were more likely younger, female, and did not have Medicare or Medicaid insurance. Another assessment based in New York City aimed at evaluating differences in telehealth use between minority and non-minority cancer patients, which concluded that there were significant differences with Black, Hispanic, and Asian patients having less utilization of both phone and video telehealth. With the increasing importance of telehealth, it's valuable to assess how it affects patients accessing telehealth at UNC Healthcare and to contextualize it with past studies on telehealth modalities. So there were three main questions that my project work sought to address. Are there differences between patient usage of phone and video telehealth across age, gender, health insurance status, the rural-urban divide, or the prescriptions that were granted to patients? Are there differences in patient wait times or visit length based on the telehealth modality used? And what do previous telehealth studies before COVID-19 conclude about patient use of phone and video modalities? The first two questions were primarily addressed through the data analysis component, while the last is covered in the context of the literature review portion. So talking about the setup for the data analysis component, the data set from UNC Urgent Care, as I mentioned, spanned from March 3rd through May 3rd, 2020, and it included over 1,800 unique visit data points, along with a variety of associated variables to examine. Some of the examined variables were about the visit itself, what modality was used, how long the visit was, what the wait time for the visit was, as well as if the patient ended up getting a prescription or not. Others involved demographic information of the patient involved, such as age, gender, whether the patient was insured, as well as their location or address. The main outcomes of interest were how modality of the telehealth visit corresponds with health disparities across age, gender, health access status across the urban-rural divide, and insurance status. Additionally, we looked at each modality to look at the wait times for the visits, the durations, as well as prescriptions given to patients. For the literature review component, the process involved two stages of development. The first, for the initial detailed review, I focused on studies that specifically compared both phone and video telehealth modalities to see its impact on the patient experience and reported outcomes. This review provided the foundation for a second, more general review, which included studies examining either one of these modalities, not necessarily both, and was incorporated as an introduction for the paper manuscript developed, highlighting why our paper may be useful and add value to the subject literature. Getting into the findings of the data analysis. Well, the table you're seeing here provides a breakdown of the composition and counts of the demographics of patients in the visit dataset across gender, age, health insurance status, health access, and whether prescriptions were prescribed or not for the patient during the visit. Phone visits comprise most of the visits at 78.4% of the total set, with a mean average of 22.8 visits daily, while video accounted for the remaining 21.6% of visits, with a daily average of 6.3 daily visits. Across both phone and video modalities, most of the patients were female at about 70.9%. Among age groups, patients between 18 to 34, ages 18 to 34 accounted for the most visits, with patients of age 35 through 50 being the next most represented age group. Across both phone and video, the least present age group were patients 65 years and older. Majority of the patients across both modes were also uninsured, and more patients did receive a prescription from the telehealth visit that they were in than not. In table one also here includes computed p-values from chi-square testing for significance in the relationship between the telehealth mode and these various categories. In addition to these chi-square values, a two-sample t-test, assuming unequal variances, Welch's t-test, was done to test if both the mean wait times and the mean duration length varied significantly across modalities. The Welch's t-test for both these factors produced p-values of less than 0.001. In addition to the above analysis, there was also development of a few graphs to produce some insight into the comparison and patterns of wait times and visit lengths for the two modalities over the time examined. Here, the wait times for patient to see a physician across phone and video visits are plotted on the left and right, respectively. They both also include the trend line for the number of physicians that were working daily, as well as the number of daily phone visits that were received. The number of physicians working daily shown in these figures peaked at a maximum of 33 physicians a day on March 21st and March 22nd. The number of phone sessions facilitated are also peaking on these days at 47 phone visits. The longest wait times were experienced across both modes by phone users in the second half of March, but both phone and video users experienced extended wait times in this same period compared to the month of April. Looking at the durations of the visits, the length of the phone visits on the left and video visits on the right indicate a maximum length of 30 minutes across both modes for the longest session. But unlike with wait times, there is not a peak around a date or series of dates for time spent in each session. However, starting in mid-March, there is an increase in the length of visit duration observed across both modes, with sessions beginning to exceed 15 minutes for the remainder of the observed period, starting on March 17th. So what are some conclusions we're able to draw from this? Well, table one, which I showed earlier, allows us to see which modality is more commonly used among which kinds of patients in this data set. With the computed p-values of the chi-square tests performed using the table one data, there was a statistical significance with p-values of 0.001 or less in the relationship between telehealth modality and variables of patient gender, age, insurance status, health access, and whether the patient was prescribed prescriptions. The main conclusion from this is that male patients, patients of age less than 18, uninsured patients, and patients residing in urban areas are more associated with video utilization for telemedicine visits. But video visit patients are less likely to receive prescriptions compared to phone visits. Also, the Welch's t-test of p-value of less than 0.001, as I mentioned earlier, for both the mean wait time and mean visit length, indicated that patients on average had a significantly longer wait time for a phone visit compared to a video visit. But in terms of the length of the visit itself, video visits were on average significantly longer than phone visits. On the graphs that I showed you, the increases observed in both wait times and length of sessions, as well as the uptick in daily visits in mid-March, could be attributed to the period where the pandemic concern got heightened here in the US, and it could be a product of canceled in-person appointments or limited access to regular healthcare means. Moving on to discussing the literature review, the focus was on examination of studies prior to COVID-19 that directly compared both phone and video modes in telehealth studies, and to compare the general conclusions of these studies to the conclusions from the data analysis of our project data. In summary, most of the reviewed studies do not offer insight into disparities and how telehealth modality may influence them, but focused on patient and provider acceptance primarily, along with some measures of health outcomes. These studies lean towards finding video telehealth implementation to be more beneficial, either in improving outcomes or more favorably received among patients compared to telephone-based encounters. The ability to communicate visual cues, increased confidence in clinician decision making, and diagnostic outcomes were some of the main reasons given. However, there were some exceptions where phone and video did not make a significant difference in experience or outcome. In these cases, the phone medium was considered more favorable due to its lower cost and lower technical complexity to implement. My full review draft with references is available in Appendix D of my written report. In terms of contrasting with our project focus, this review found that there are some underexplored factors in existing literature on phone and video modalities that this project focuses on. There's limited research on the comparative usage of both modalities by patients, which is a serious concern for the current context of COVID-19. Specifically, a gap in literature exists for the linkage between phone and video visits and factors like health access, disparities, and service outcomes. Also, some of the existing literature comparing telehealth efforts across these modes are limited in generalizability due to the selection of patients usually based on convenient sampling, limited or specialized scope, or strict exclusion criteria. Segments of this developed review was incorporated into the introduction and discussion segments of the co-authored manuscript. An abridged manuscript draft is available with references in Appendix E of my written report. So what are some examples of challenges that were faced in the project? Well, one of the challenges with the internship experience is the wrangling and the appropriate handling of raw data to make meaningful use of it for analysis. This could come down to different factors such as differing assumptions about what data points may indicate, or different definitions about what constitutes a specific category or classification. It could originate from messiness in the data or errors in the input of data into the database. One example in this project was a labeling of the rural and urban classifications across each visit data point. There was discussion and iteration in classifying what would be considered an urban or rural location, whether it would be based on the patient's residential address or the location from which the visit was being initiated. These were not always the same. And if the designation should be determined primarily from the zip code part of the address, or should it be from the county or the city itself? Well, an iterative process of clarifying our categorization criteria based on clear definitions and then cleaning the data to ensure that the data is accurately represented in these categories was helpful to address this. Some other challenges were linked with the limitations of our own study and data set involved. As we noted in the limitations sections of the manuscript available in Appendix E, the dataset we used is from an on-demand telehealth service where patients choose between the modalities, so there was not randomization of patients. There was also no data capturing ethnicity or insurance type, which could illuminate more on the patterns in preferred telehealth mode or any associated disparities. Another challenge was the attempt to determine if there was a meaningful relationship between the various variables in the dataset and the difference in prescription rates, whether one prescription or two or three or more prescriptions were given to the patient. However, there was not a significant relationship found through our attempted analysis. There's possible confounding in the difference in prescription rates due to the various diagnoses that patients received in the visits of this dataset. A professional challenge and growth opportunity for me in this experience was to get more familiar and experiment with using programmatic tools for analysis, as opposed to leaning exclusively on Microsoft Excel for data analysis purposes. While the use of pivot tables in Excel was helpful for some analysis, it did prove to be more laborious for running multiple chi-square tests or for data wrangling or stratifying within a specific data category. Getting some exposure to learning how to use tools like R and Python to accomplish this was helpful for better optimizing the data wrangling and analysis process. Finally, a unique challenge in this specific window of time was that the internship was fully online, working remotely in a collaborative manner. Throughout the entire span of the internship, communication was either done by teleconferencing, email, or online collaboration tools such as Office 365 and OneDrive. As such, it was essential to communicate often and clearly. It was also essential to practice and implement careful safeguards while working with online services to not lose or compromise the data we had or to lose the work being developed along the way. So, to wrap up, reflecting on the lessons I've learned in this experience, one of the valuable lessons from this experience is understanding how determinants of health can relate to the use of modalities of telehealth, and that this should be considered during implementation of telemedicine going forward. Doing this can help mitigate existing disparities, but ignoring this has the potential to worsen them. Additionally, this experience for me required a certification of completing some ethics training for IRB approval on working on human research data. And for me, it showed the additional level of concerns that come with working with healthcare data than working with purely commercial or logistical data as I've done previously. It was also illuminating to work in an academic research setting and to contrast how the research process and manuscript development works in this context compared to deliverables or reports in other professional settings. As noted in the challenges section, I've also gained a deeper appreciation for the possible efficiencies and capabilities of using programmatic tools in the data cleaning and analysis process, and I seek to learn to use them more effectively where tools like Excel might be limiting in the future. Finally, working in an all remote setting throughout this internship has highlighted the value of clear, effective written and verbal communication and the need to manage assigned independent work carefully to keep the project on schedule. These are professional skills that will carry across industries and into the future. In terms of acknowledgements, I want to reiterate my thanks to Dr. Saif Khairat, who recruited me to work on this project and mentored me throughout the experience. PhD student Malvika Pillai also deserves recognition for being a cooperative collaborator and providing helpful insight and resources while working on the project. I also want to give credit to my faculty advisor, Dr. Javed Mustafa, as well as CHIP program coordinator, Mariel Ruiz, for working with me to secure and improve this internship opportunity, especially during a difficult season brought about by the COVID-19 pandemic. But overall, as I reflect towards the end of my program here, I'm grateful for all the instructors and fellow students that I've worked with to get to this point. So here are my references I cited in the slides, but the full list of references used for my project are available either at the end of the slide deck uh, or in my full written report and the corresponding appendices. So that concludes my presentation. As I mentioned, my full written report and appendix are available. If you're interested, just let me know. I'm happy to answer any questions that you may have. And if I'm not able to give an immediate response right here, I'll be willing to get back to you via email. Thank you for your time.